Hi, everyone. Welcome to the Waldenstrom's Patient Physician Partners Program. My name is Tiffany Drummond. I'm an advocate who has worked in cancer research for 20 years, if you can believe that. But more importantly, I became a care partner and advocate when my mom was diagnosed with endometrial cancer in 2014. Her journey led me on a quest to find out as much information as I could to help with her care, and quite honestly, it wasn't easy to find. And that's why we at The Patient Story put on a program like today's to help people navigate life after diagnosis. This program is hosted by The Patient Story. Our multi-platform organization aims to help people navigate life before, at, and after diagnosis in human terms through in-depth patient stories and educational discussions just like this one, focused on how patients and caregivers partners can best communicate with their doctors as they go from diagnosis through treatment in Waldenstrom's. We want to thank the Leukemia and Lymphoma Society for its partnership in this. The LLS offers incredible free resources like their information specialist to help you communicate with members of your own healthcare team and provide information about treatment options. And we have the IWMF, an organization specifically dedicated to Waldenstrom's patients and care partners that also offers free resources like their in-person support groups. They have over 60 worldwide. Okay, so make sure that you check them out as well. Before we get to our speakers, we want to thank our sponsor, Pharmacyclics, an AbbVie company, for its support, which help us to host more of these programs and always for free to our audience. The Patient Story retains full editorial control over all content, always. Now, I hope this was helpful. Please keep in mind, this program is not a substitute for medical advice. One last thing, we know there's a lot that you want to know more about and discuss, so please let us know what those are, along with what we could do better. So there will be a survey at the end of this program, so make sure you tune in and find out to watch, okay? So Stephanie, the Patient Story founder and a blood cancer survivor herself, will lead this conversation. But first, let's start with the Waldenstrom's patient voice today. Jason, tell us about yourself.
My name is Jason Euzukonis. I'm just turned 50 years old. I have two children that are 13 and 10. I'm married, live on the North Shore of Massachusetts. Avid runner, sales rep in the athletic footwear industry, and I was diagnosed with Waldenstrom's macroglobulinemia in June of 2018.
Thank you, Jason. Really appreciate that. And our other incredible panelist, if you will, leading the conversation today, Dr. Sarosiek, whom we've had the pleasure of collaborating with before and have heard so many great things. Dr. Sarosiek, can you give us a little bit about who you are, what you do? You have a long list of on your resume, really, and also what drew you to this specialty in particular.
Sure. Yeah, I'm happy to be here today. Thanks for having me again. I am a hematologist oncologist. I work at Dana-Farber. Currently, I work in the Bing Center for Waldenstrm macroglobulinemia, so that's what I specialize in now. But I originally trained in medical school at University of Miami, and then did residency and fellowship at Boston Medical Center and Boston University, and now I've been at Dana-Farber for about 4 years now, and really enjoy what I do, subspecializing in Waldenstrom's care.
Thank you so much for that. Excited to get into this conversation. I want to go over again, really the focus of this. The focus of this conversation is really less clinical than some of our other programs have been, and really focuses on, we hear all the time about shared treatment decision-making or empowered patient or self-advocacy. And I think sometimes it can get a little bit lost in the mix because it's so conceptual. There's a lot of conversation about it without maybe specific examples. Our goal today is to showcase not the only kind of communication that can happen, not the only relationship that can happen between a physician and a patient, but to really showcase what great looks like, because for both Jason and Dr. Sarosiek, it's been a really great relationship. And a lot of that, I think, is centered on communication and this sort of long-term relationship building. And so we're going to go through from the diagnosis, where we're really going to talk to Jason more about finding Dr. Sarosiek, and then lean into, at every major decision point, what was the conversation like, and we'll kind of go from there. So having said all that, Jason, let's start with I know you talked before about the symptoms. They're usually not maybe that obvious. For you, what were the signs that something wasn't right? And what was the first physician you went to go see?
Yeah, the real sign that something was wrong is, I'm a runner. I know my body well. I would say in the spring of 2018, I really started noticing some symptoms or signs that something wasn't right. I can go out for a run, feel tired, but still slog through a few miles. But I started feeling some fatigue that just really felt off. I would get 3 or 4 minutes into the run, and it felt like my body was just shutting down. It felt like blood and oxygen just weren't getting out to my muscles. And it turned out that after I learned the diagnosis, it turned out that's kind of exactly what was happening. So that's what led me to start going down the path of trying to figure out what was going on. I went to my primary care that led me to a hematologist. Then from there, sort of a general lymphoma specialist. So I went through multiple steps before I ended up at Dana-Farber, working with a team that really specialized in my subtype of non-Hodgkin's lymphoma.
Thank you. I want to dive into some of this because I think a lot of it will resonate. Different parts of your story are going to resonate with different people who are watching this. So first, as we know, primary care, there are not cancer specialists. Yours had ordered blood work, some labs, did see something was wrong. But your self-advocacy started pretty quickly on. Can you describe that?
Yeah, I think it really started when I got to the hematologist. So the primary care physician, they at least were able to identify that, yeah, something is really not right because I was very anemic to the point where they had me come in quickly to within a day or two just to make sure blood counts weren't crashing in case there was some sort of internal bleeding, in which case they would have wanted me to go to the emergency room. But things at least seemed stable, even though the blood counts were low. And that's when they kicked me over to the hematologist. But even there, as I look back now, is great. There's certainly a role for hematologists, of course, but even then, especially for my situation with a rare type of non-Hodgkin's lymphoma, you kind of want to go to another level in my situation. So that's when I really started doing more research and realized that, okay, maybe I need to get to someone that really knows the disease. And there were some things that hematologist said that kind of jumped out at me. I remember when they were talking about treatment, the line that jumped out to me that didn't feel right was, well, we treat all these subtypes of non-Hodgkin's lymphoma the same way with chemotherapy. And I thought, it didn't sound right to me. So I happened to be fortunate that I knew someone that worked in a lab at another medical center in Boston that was not Dana-Farber, actually. But they got me into there. And that's when we started taking a deeper dive and we were able to really get the true diagnosis of Waldenstrom's macroglobulinemia. And they were great over there. But during that time, and this is why I think it's really important as a patient to continue doing research. And that's when when you do a search for Waldenstrom's macroglobulinemia, it's not going to be too hard to find the Bing Center at Dana-Farber. And when I realized there was a team there that's really truly specialized in my cancer, then that's when the real journey began of getting over to that team. I kind of just felt like, all right, the more I can work with doctors that truly know this disease inside and out, the better it'll give my chances of living a normal lifespan. So, yeah.
Jason, I appreciate you sharing all that. I also, you had mentioned before in a previous conversation, you're you love research, you're a bit of a nerd in that way. I think what you said, or a geek, you use that word, not mine. And so
don't laugh, Dr. Sarosiek.
Birds of a feather here.
That's good. Yeah, that's part of the success. For the people who are watching who are not like that, right? I think sometimes there are different things that pop up in our head. Even I was a journalist. I still consider myself one, but I was a professional journalist before. And even being a research geek myself, when I got to become a patient in a doctor's office, I often felt very self-conscious about being labeled a problematic patient, which I think I just defined as asking too many questions. So for you, did you have to get over any hump like that? Even though that's, your nature to ask questions, to want to know. And second to that, do you have guidance for those of us out there who have even less of that affinity for asking questions or wanting to take up that space?
I didn't have a problem getting over that. My life was on the line. I mean, I'm naturally curious anyways. And I do like to when I get on certain topics, I like to really take a deep dive and learn as much as I can. But I'm definitely not someone that has any problem asking questions. That said, I know there are a lot of patients out there where that can be a challenging thing. And that's a tough one. I guess at the end of the day, if for those folks that do have a difficult time talking to doctors or asking them questions, get your family involved, because there's likely someone in the family that will take the bull by the horns. We've actually had to deal with that in our own family, where an older relative got a difficult diagnosis, but that, especially that generation, they tend to be a little bit more shy about questioning the doctor. But I think good doctors have no problem with patients asking questions and probably prefer that. So that, I guess, for someone that is shy about asking their doctor more questions and feel like they're challenging them, maybe get some members of the family or friends, whatever, let them know the situation, because there likely is somebody in their circles that will be more familiar with what to do and what questions to ask.
Great. Thank you, Jason. Dr. Sarosiek, first of all, can you describe how many years have you been focused on Waldenström's, and how many patients do you see, maybe each, like an average, like each, I don't know, but like each year or something like that? Yeah.
So I've been focusing on Waldenström's for about 4 years now at Dana-Farber. Since I came over to Dana-Farber, I see about, it varies a little bit, 30 to 40 patients a week, and the vast majority of them are Waldenström's. I see, some of those patients or a few of those patients might be patients with precursor to Waldenström, so MGUS or related disorders. So a small percentage of them, are pre-Waldenström's diagnosis, but the vast majority of those have Waldenström. So we're pretty lucky to be able to really focus in and just see one thing.
The reason I ask before I ask the follow-up question is to give the context, right? So you're seeing 30 to 40 patients a week, a majority of them Waldenström's, some of them precursor with MGUS. And whereas in the community, these hematologist oncologists are seeing everybody across the board. So they may only see 1 or 2, maybe Waldenström's patients a year. I mean, something to that effect, right?
That's exactly right.
So Dr. Sarosiek, what is your guidance to people about this, this idea of most people are probably going to see, similar to Jason's trajectory of, you start somewhere and you maybe end up at a community provider, and then you might end up at someone like yourself. What is your guidance to people on how to get to a specialist and the importance of that?
Yeah, I think obviously because of what I do, I really think that it's really important, if you can, to get to a specialist in whatever way that you can. I think if you are able to and have the means to go to see a specialist, I think that's the best, because you can really have this one-on-one dedicated time. Sometimes there are other ways of getting a specialist's opinion. If you are unable to travel, there are, like for example, Dana-Farber offers grand rounds where you can send in your records, and then physicians can review it. There are also a lot of employers that have second opinion programs through the job. So I think that's a good idea for patients to look into that, where the employer provides the ability to give your records, and a physician can give a second opinion. Those physicians are typically at large academic centers that specialize in the disease. So I think, sometimes, and even through some support groups, you can also access some opinions of physicians as well. It wouldn't be exactly for your case, but at least it might be a way for the patient to inform themselves and learn a little bit. But if possible, I really think it's a good idea. I mean, having practiced for a few years before I came to Dana-Farber, like you said, I saw a handful of Waldenström's patients a year, and I never could have known all the literature that there was to know about Waldenström's then, or any other particular disease. And if you're able to go to see someone who's a specialist, they might be able to just be a little bit better about tailoring your care around all of the literature in that one disease. And I think the other part that I really try to do with my patients, hopefully I'm okay at it, but I do try to recognize that when patients come to see me, that typically they're seeing their local doctors, who are usually excellent physicians, but don't know all the details. And so I try to give all the patients, all the time I can to be able to ask those questions and really have the time to really dig deep into their disease while they're with me, knowing that, it's not possible in the community to really specialize in Waldenström's.
Quick question about that, because so many people, I think we hear go see a specialist, but logistically speaking, for some people that might seem daunting. Do I have to travel every single time, especially if this is something I'm going to have to be minding for a long while? So how does that work? Do you have relationships where patients see you as the specialist, but they're getting their blood draws and some of the routine care closer to home?
Yeah, we have a lot of cases, where patients really do what works best for them. And that's typically at the end of a new patient consult, the conversation I have with each patient. So patients who live nearby or are able to travel to see us, we have, an ongoing relationship with routine care and routine blood work at our center. But a lot of our patients can't travel. And so they have a local oncologist that we're willing to work closely with. So they might just have their local work and their routine follow-up there. Patients often will come to see us maybe once a year, and then we can remain during that year available to them for questions or concerns. Sometimes we might just do an initial consult and then just tell the patient if something comes up in the future. Now that we have a little bit of their background, their local oncologist can reach out to us with questions or concerns, or they can come back when and if they have to make a big treatment decision. So we really can tailor it to what works best for the patients in terms of their ability to visit our center.
That's wonderful. Thank you so much. It sounds like you are as flexible as you possibly could be to meet the different situations that patients and care partners have. So before we dive into the next sort of phase of the conversation that happened between the two of you, I know, Jason, you had mentioned, I know mental health is something that we talked about even last time. Dr. Sarosiek with our program focused on mental health. It's a huge part of every diagnosis, but in this one, of course, because it's long-term, a huge part of the consideration. Jason, the first place you were at, you were there for a year before you went to Dana-Farber and before you saw Dr. Sarosiek. You talked about, hey, maybe the treatment plan was similar. Maybe the guidance wouldn't be so different there, but it was other things that made all the difference in the world for you. Could you describe what were those things that was a very clear difference between where you were before to when you met Dr. Sarosiek and her team?
You mean in terms of the approach at Dana-Farber and their versus I felt like the hospital I was at, the doctor I was seeing before Dana-Farber, there wasn't as much back and forth in terms of the decision making. It was very much, here's what we're going to do, and that's that. And I just kind of felt like, I don't know if that's quite the right approach. It's just my gut told me that I feel like there should be more back and forth, more discussion between the patient and the doctor. And by the time I got to Dana-Farber about a year after my diagnosis, after being at that other hospital for a year, I was just really, I couldn't believe the difference. Literally my first appointment, I actually had worked briefly with another doctor before I found Dr. Sarosiek, but that doctor was phenomenal. And I remember him just kind of sitting back and saying, "What questions do you have?" It took more time than any other doctor I'd ever met with before, and that turns out to be it seems to be the case with the whole team at Dana-Farber. But I just think that's something important for all patients to remember, is that if you feel like you're getting rushed, if you feel like there's not a good discussion back and forth with your doctor, then you might want to see if there are other options. So yeah, that it was just such a big difference, not just between Dana-Farber and that one hospital, but almost any other doctor I've met with before. So,
right. And beyond the fact that you described, well, the previous doctor at this other institute, like this other hospital, was really smart and knew her stuff. But what really was the impact was the quality of life issue. I mean, the mental health. You described that year of daily having to move through. Can you describe the daily impact? And then what shifted for you after you moved to treatment centers?
I mean, that first year after diagnosis was just a massive amount of anxiety. And woke up every morning, just I could feel it in my chest, and I had to go through a process every day that started I started every day with just spending, a good solid half hour just in quiet meditation. Fortunately for me, I'm kind of an early riser, so I'm up before the family anyway. So I do get that moment of quiet. But it started with a lot of meditation, and I just sort of thought about my body healing. Whether people believe that works for them or not, the point is to find things that help you get through your day and help, at the end of the day, we've got to get used to living with this cancer and living a long time with this cancer. So you have to, and at some point you've got to get back to your, once you start to feel better, getting back to your routine in terms of work. And in my case, raising a young family. So meditation was huge for me. I changed the way I eat. So I felt like I lost control of my health. So I was trying to do whatever I could to reclaim that control. So I just changed the way I eat. I was able to get back to exercise, and that's all relative. It doesn't have to be an intense form of exercise. It's simply moving, going for a walk, whatever, gardening, anything to get moving, I think is helpful. Those were the things that I did. And I did hear Dr. Sarosiek say one other thing earlier that I forgot to mention that is critical as well, is support groups. Support groups are I think a critical component towards moving forward and with your mental health. There's a lot of people that have been through some really difficult journeys in those groups. You can learn a lot, both not just about mental health, but your chances are, if you're dealing with something, there's a good chance somebody else in that support group has been dealing with the same thing at some point. So those are another great way to help with your mental health, talking to others that are on the same journey. Because a cancer diagnosis can feel very lonely. And being around others that are going through that, I think, is really helpful.
Absolutely. I know you lead a couple for the IWMF in terms of support groups, and we'll make sure to drop links for any resources that would be helpful to people. So thank you both for highlighting that. Dr. Sarosiek, hearing some of Jason's journey to you, have you, how often are you sort of seeing patients who are in a very similar space? They've been in a place where they've been, basically told what to do. What are you noticing from the patients you're seeing in Waldenstrom's, and how do you approach them when you first meet them?
Yeah, I would say a couple of things. So one, I think a lot of people are in the same situation as Jason was originally. Patients will come to see me and they'll say, okay, so what would you do for my treatment? This is what I was told I have to do. And luckily in this space, particularly with Waldenstrom's, we often have quite a few options. And then sometimes I lay out the options and patients say, oh, I wasn't told that there was something else that I could do. So I think that is true that and some patients, don't know that there are other options. And that's an important part of seeing a specialist. So, and I do think a lot of patients, I've learned this the longer I've been in Waldenstrom's, and I think it's different for every cancer, but a lot of patients, face something similar to Jason. And I can't speak to this personally, but, patients come to see me, and initially around the time of diagnosis, really it is an everyday, day in, day out thing where you're thinking about the disease and you're worrying about the future and that type of thing. And it's a journey, I think, for patients as they get used to living with this disease and kind of restructuring their life around the disease. And I'm learning, the longer I'm working with patients, I think I have to change a little bit who I am for the patient, depending on where they are in that journey. Because initially, I'll know that patients will have a lot of questions and a lot of anxieties initially. And I even try to say sometimes, like, this is a time where, just ask questions, because relieving your anxiety or getting questions answered is really important thing to do right now. And I even say, I look forward to the time, at one point you're going to kind of, learn to live with this and feel more relaxed. And it's not going to be the only thing on the front of your mind all the time. And so I kind of, try to adjust with patients as they kind of work their way through that journey, because it is a life-changing thing, but it also changes during the time that they're living with the disease as well.
I can really appreciate that. And I can also appreciate that you probably see like a wide variety of different kinds of people, maybe different personalities and preferences and all those things. So to generalize, I know that there's so much more depth to this, but if you could generalize different kinds of patients and care partners who walk through the door, right? So maybe they're like, one way of thinking about it be Jason, very research oriented, no problem asking questions, What are the other kinds of people who you're largely seeing who are maybe not the same? And what is your guidance to them on how to approach, whether it's meeting you or somebody else after a Waldenstrom's diagnosis?
Yeah, I think that is something that, I try to feel out during an appointment is, who am I meeting with and what works best for them? Many of our patients, I think that come to Dana-Farber for a second opinion, we do tend to have this population of patients that really want to ask more questions and want more information. But sometimes as I talk to the patients in the first few minutes, some patients are overwhelmed by a lot of information, especially at the beginning. And I, try to tailor what I'm saying or what I'm offering, or, in that first appointment in terms of information, I might limit it. And then they might be someone that wants to learn more after they get over the initial shock or the anxiety about the diagnosis. Or sometimes it's patients that they really feel like they just want more guidance from me rather than just me leaving the decision up to them after I put out the option. So I think, there are a lot of different people, a lot of different personalities, and I try to feel that out. So hopefully I can, best serve that patient in the way that would make them most comfortable with their disease.
Are there any questions, like top 3 questions you recommend that patients are asking their doctor after the Waldenstrom's diagnosis to help, regardless of their background, just 3 questions or however many that would be pretty key in helping them to understand the disease better and how the care is going to follow?
Yeah, I think, some of the key things that patients ask, and I try to walk through, is one, I think it's helpful. A lot of patients want to confirm, do they have the right diagnosis? I think most of the time when patients come to see me, they do, but occasionally that's not the case. And so part of what we always do in that initial visit is kind of walk through what do we want to see to confirm that a patient has Waldenstrom's. And I think that, no one wants to hear that they have cancer, but I think sometimes that helps patients to understand, yes, everything lines up. Yes, this is the cancer that I have. So now I can kind of move forward without having doubts about that. I think that it's really important to ask, what are my treatment options? And if you're told just one thing, to ask, are there other things that I could consider as my, options? Are there alternatives? Most cancers do, not all of them, but most have, listed in the NCCN or the cancer treatment guidelines, multiple options for treatment. And then having patients kind of ask, what are the, differences on the, with the treatment. And that depends on what really the patient's goals are. Like, what are the difference in side effects, or how long I'm on treatment, or that type of thing, so that the patient can help tailor their treatment to what their goals are in their life. And then I think another key thing that I always try to talk with patients about, or that I often hear as a question, is, what do I need to look at going forward? Especially, like, what are the most important markers, particularly Waldenstrom's? We watch IgM, or we watch for anemia. And I think that's another key thing that often helps patients to feel a sense of control, is if they know exactly when should they be following up and what should they be looking for. Because we always check labs, or 100 values that will come up on any patient portal for any visit. But, with them knowing exactly what are the things to watch closely for, the key markers, I think that empowers the patient to really know what's going on with their disease and how to follow it.
Wonderful. Before we move into treatment decision-making, conversation more tied specifically to that, first of all, I've heard control come up a couple of times, and that resonates with me as well, right? This sort of sense of, how do I regain the control, and understanding that maybe from the patient and care partner perspective, that's very top of mind. What is the recommendation from you both when there's obviously a lot of emotions in the initial conversations? The first meeting, like you said, Dr. Sarosiek, some people are clearly overwhelmed, and you recognize that they may not be able to, or want to, have to hear and digest a ton of information. So you tailor the conversation to them. But what is your recommendation to people on, is there anything else that can help them in the beginning? And especially, not the two of you, but for Jason, when you had some problems feeling heard, maybe, or feeling like an actual participant and partner in the conversation, what is your recommendation to people on how to regain that, and maybe even to talk specifically through, well, I was with these doctors, these are the pushback, these are the things they told me, here's how I navigated that. Can we start with you, and then Dr. Sarosiek after that? Would be great to hear from your perspective, even though you're not that doctor. maybe the perspective from the physician on why, and how patients and care partners can navigate those difficult conversations as well. So Jason, let's start with you.
Yeah, I guess the doctor that I saw before I got to Dana-Farber, I mean, in retrospect, I probably should have just been more upfront with them and say, hey, listen, I'd like you to hear me out a little bit more. And, are you willing to, are you okay with me asking more questions? Because I think a lot of people just have a hard time getting past that hurdle. I wish I just would have been more upfront with that doctor, because for all I know, maybe they were more open to a back and forth with the patient. I think the challenge that doctor ran into is at that particular center, they were just overwhelmed. The healthcare system was very taxed. It did kind of feel like there was this one patient after another there. It just felt like they didn't really have the time. And I don't think that was the fault of the doctor. But at the end of the day, it's your life, and you've got a certain amount of time with a doctor. And I think it's just really a matter of being more upfront with the doctor, and telling them if you've got any sort of, if you're not comfortable with where things are at with the relationship. I don't know if that answers the question or what you're getting at there, but.
Absolutely. It's a great example. And thank you for pointing out. It's true. The systems are quite inundated, unfortunately. Yeah. And time is the biggest resource that is unavailable all the time. So thank you, Jason. Dr. Sarosiek, anything to add there?
Yeah, I would say, I totally agree with Jason. As a physician, I agree, there are a lot of time constraints in terms of seeing patients and other responsibilities and things like that. But, sometimes maybe if you could ask your physician, like, what is the best way for me to ask questions? Because maybe there isn't time in that initial appointment, and maybe not at the fault of the doctor, who knows, because maybe they have a full schedule. But if they say, you can reach out to me through the patient portal, or talk to my nurse, who's, an excellent resource, or, some patients email, and if they're comfortable with that, that's another thing. I think you just have to try to see with your physician, like, what's the best way that they feel comfortable, and a way that you feel comfortable kind of communicating. If you can't get all of that done in a clinic appointment, then, is there another way? Because I think that's a key part of the relationship, is just, as a physician, I feel like it's important to be available if questions come up, particularly as we were talking about at the beginning, when there are a lot of anxieties surrounding, or a lot of questions surrounding a diagnosis. And then even as time goes on, there can be things that pop up that you say, is this something I should worry about? And I think you just have to have a comfortable way to reach out to your provider to be able to ask those questions.
I think that's great advice. Before actually we move on, something you said made me think of another question, which is, you see so many Waldenstrom's patients and family members and care partners and caregivers. What is your message to people to the healthcare providers, to the physicians who don't see so many, who may not understand how to navigate the conversation? What are your top tips for them on how to navigate these conversations in the beginning?
I don't know exactly the secret to this, but I do think that as a physician, it's important to know that we don't know everything. I know a lot about Waldenstrom's, but still I don't know everything. And I certainly don't know a lot about things outside of Waldenstrom's. And I think it's just important for us all to realize that we have limitations, and to be open to hearing from other people. We try at our institution, I think a lot of other places do exactly the same thing, to just be available to other people, other providers that might not have expertise. And so I usually try to tell patients and to tell their local doctor, I'm more than happy to answer questions or be available. And so I think for physicians who don't have all the expertise, I think they shouldn't hesitate to reach out to specialists at larger academic centers, and just feel free to ask questions, or people who email us a lot. And I don't know who they are. I haven't personally interacted with this oncologist before, but we're happy to answer questions, because I think the goal for all of us is really providing the best care. So I think as a physician, it's important to just be open to learning. I do it all the time. I see patients that have maybe other clinical questions or needs that I don't know about, and I reach out to the other specialists in the different fields to try to answer those questions. So we all just have to be open to learning, and open to asking other people questions when we don't know the answers.
It's really refreshing to hear. I love that. Open to learning, open to asking questions when we don't know the answers, which I think for all of us is for a lot of the different times. So thank you so much for that. Diving into, of course, it's a rapid shifting landscape of treatment options in lymphomas, non-Hodgkin lymphoma, including Waldenstrom's. And so there's a lot of discussion we're hoping can happen in the clinic between the physician and the patient. Jason, before you met Dr. Sarosiek and Dana Farber, what was that first? Where was your mind in terms of wanting to understand treatment options, and what was that first conversation like with the other physician?
Yeah, that was a very difficult time, a very different time in terms of my own journey, in the sense that I didn't know even remotely what I know now. So I was still very much in the mindset of doing whatever the doctor said. Although as I got deeper into the journey, that's when I realized, like, oh, wow, there are other options. But I pretty much initially just did what the doctor said. My treatment options are a tad more limited than the average Waldenstrom's patient, most likely, and just in the sense that chemotherapy, not that it's not an option, it's just not a great option for me. So I think in retrospect, the good news is that doctor at the previous hospital did put me on the right path. So I'm grateful for that. But it just so happened that I didn't even really know about the other options anyways. And I likely would have, like I said, I started with that same option. But I definitely was not in the mindset of having this back and forth. But as I got a lot more informed as time went on, then, I kind of realized the right questions to ask, but I did not know them back then.
I got you. Yeah. Well, there's a lot to learn for everybody, I think, in that position. Dr. Sarosiek, how do you, share, define even what Waldenstrom's is as a diagnosis with the patient at that first meeting? And then how do you enter that conversation? What is top of mind for you as you try to lay out treatment options?
So usually I do some, quite poor art where I try to draw out, what is the bone marrow and how's the IgM coming out of the bone marrow. I don't, I usually try to explain it. And then I really do try to do a little bit of a drawing, because some people are more visual and other people like to hear it. So I kind of do a little bit of that. And then, usually I try to, either I open a conversation with a patient, or I give a little bit of background about Waldenstrom's, and then I try to move into the part where I just ask the patient, what are the questions that they came with that day, or what do they want to know? Because usually at a first appointment, patients, have something that's at the forefront of their mind, or they have a list of questions. And, if they're thinking in the back of their mind, how long am I going to survive with this cancer? And then I'm spewing out a lot of other information about other things that they don't really care about before I answer the question that's really most burning. I think it's not super helpful. So I do often try to just say, what questions do you have? And then that kind of guides the conversation. And ultimately, we often end up covering the same things at every new patient appointment that I have with a patient with Waldenstrom's, but we might get to it in a different order or a different way, just depending on what is most important for the patient. So it starts with a horrible drawing and then moves into whatever the patient really wants to know about.
We're going to have to get some version of that drawing for this program, Dr. Sarosiek. I'm sorry, that's just going to have to be the case. And you could assign it. So it sounds like the initial meetings, you're meeting people where they are. At some point, which is the appointment that tends to be all right, here's how I'm going to lay out the treatment options? Does it tend to be not the first meeting then, it's the second one? Or, and then whenever that happens, how do you lay out the options in a way that people will understand and their impact to quality of life?
So there is a small percentage of patients that need treatment immediately. And those patients in the first conversation, that we meet, we go through the diagnosis and then we jump right into treatment options. But there are a lot of patients that have...
Dr. Sarosiek, actually, before you go into the other patients, the majority of patients, for the smaller number of patients, what's that profile? Why do they need treatment? How do you explain to them why they need treatment faster than other patients with Waldenstrom's?
Yeah, so a lot of our patients present, similar to what Jason described, where they have pretty significant anemia, and that's how their disease was brought to their attention, that they have symptoms that need to be addressed right away. So in the case of Waldenstrom's, most patients, the reason they need treatment is they have anemia, and that's why they presented to their doctor to work up the symptoms of their anemia. Another percentage of the patients will have hyperviscosity or thickened blood that's causing symptoms related to their Waldenströms. And so in those cases, patients need treatment typically right away if they presented because of those symptoms. So we jump into treatment discussions right away. Some patients, come to us because their disease was incidentally diagnosed. So let's say they were having routine blood testing for, their annual checkup with their primary doctor, and they were noted to have high protein or just maybe very mild anemia that's not causing any symptoms. And in those cases, we really have the opportunity to kind of discuss treatment later on. We often don't get to treatment in the first visit, and that comes up months or even years later.
When you do, for the majority of patients, talk about the treatment decisions, how do you lay these out for them?
So I usually walk through, what are the options? Often with Waldenström's, we'll have, 2 or maybe 3 different options. And I typically just kind of write out what those are and give the big picture details. Like, is this a treatment you stay on for years, or is it a limited therapy? What are the main side effects that patients can experience? And what are the biggest risks that we worry about with each of those treatments? So that I kind of give those broad information about the treatments. And then the next thing is, I kind of try to figure out what might be most important to the patient. Like, are they someone that doesn't want to be on a pill every day? Or are they someone that would hate to take a pill? They would miss it all the time. And, that kind of information helps me to guide the patient on which of those treatment options that might be better for them.
Can we go into specifics of what are the major courses of treatment that you would, offer up? And you mentioned there's the continuous, and then there's like the limited, and what patient profile, you might be more prone to saying, hey, you might want to consider this versus this.
Yeah, so for Waldenström's particularly, 2 of the main treatments that we talk about when we think about treatment, one is chemotherapy or chemoimmunotherapy. So it's chemotherapy with an immune therapy together. It's an IV therapy. It's time limited, usually 4 to 6 months. So some patients really prefer that, to have a very time limited therapy. There are risks associated with that, particularly infections. There is a small risk of damage to the healthy cells in the bone marrow. So that's an important conversation, I think, to bring up with patients. And then the other, on the other end of the spectrum is another treatment option, which is oral therapy, pills that patients take every day. And it's continuous as long as your disease is responding, which is often for years. And so it's a little bit easier in terms of you're not getting an aggressive therapy kind of right up front with all of the treatment at once. It's kind of a low level therapy all the time. And there are risks associated with that. For example, a small risk of heart side effects, but in a patient that has severe heart disease, I might stray away from using that as a first option. And then there are some options kind of in between. It's not chemotherapy, but it's injections. And, we use those in a small percentage of people, more targeted therapies that are injections. So luckily, in Waldenström's, there are a lot of different options.
Wonderful. Before we go to you, Jason, to talk about your mindset when you were, discussing treatment options, Dr. Sarosiek, what are some of the most common questions you're getting from patients, and and how do you, are there some that rise to the top, 3 of the most popular questions you're getting when you're introducing these treatment options?
Yeah, I think some of the important questions is, how will I be able to live my life during these treatments? Many of our patients are still working, they have families to raise, they have other things that are really important to them. And so they ask, what will my day-to-day life look like? And really an important question also for patients is, how will this treatment look to people around me? Will I lose my hair? Will I be constantly sick? Because that's a huge part of how patients can deal with and move forward with their disease. And so I think that's the biggest thing, is how will my life look like on the treatment? Probably the next important question that patients ask is, how long is this treatment going to work for? Like, what's going to happen with my disease if I start this treatment? Am I going to need more treatment again in a year or 2 years, or that sort of thing? And then I think probably the third one is, what's the worst thing that could happen to me from this treatment? Like, what are the scariest risks associated with the treatment?
Thank you. Jason, I know you were on your first treatment, your first line of therapy before you went to Dana-Farber, and that was a BTKI inhibitor. You had some rituximab infusions earlier on, but you were on the daily pill. What was that like for you? What were the considerations for you before you met with the Dana-Farber team?
Yeah, I mean, like I said, at the time I was diagnosed, there weren't quite as many options as there are now. So I'm a lot more at ease knowing that there are a lot of good options on the table for me when the time comes. So I was already responding well to a BTK inhibitor, ibrutinib at the time. By the time I got to Dana-Farber, so there wasn't really a need to change it. I guess probably the more relevant question from someone in my shoes is, had chemotherapy been an option, which way do you go? That's a common question. There's pros and cons, as Dr. Sarosiek mentioned, to both approaches. I likely still, had both been an option for me personally, and everybody's different, I likely still would have chosen the same path of ibrutinib, the BTKI inhibitor. I think as a younger patient, there are some things to think about in terms of long-term potential side effects of chemotherapy versus a targeted therapy. I'm in pretty good health overall. Younger, don't have heart issues, so I wasn't all that concerned about the heart, any potential side effects surrounding my heart. So that said, Dr. Sarosiek and I did have to make a decision on treatment a couple of years back when I was starting to experience some side effects, nothing overly threatening, but more annoying. And I think I had approached her and said, "Hey, what do you think about cutting the dose?" And that's when I guess leads into the conversation about shared decision making. But then that's when she had presented, how about this newer version of the targeted therapy. So I guess probably the best example of, the decision making with Dr. Sarosiek that I think put me on the right path there.
Amazing, yeah. And what I appreciate too about this is, before we go into the shifting the course, you had clearly done enough research where you even knew to ask about something like lowering dosage. So what got you to that point, and what were your considerations when you were thinking about, would you prefer to stay on something that had been working, right? And could you deal with the side effects versus shifting completely off? Take us through your thought process there.
Yeah, at the end of the day, there's just part of it is just, certain amount of trust in your doctor. Like, I have my feelings on things, but I, quite literally trust Dr. Sarosiek with my life. So, but at the same time, I think, this is where hopefully people do their homework and read up on the, what's latest and greatest. And I'm definitely someone that's a fan of the new stuff, I guess, if you want to put it that way. So I think and I had already read up a bit on the newer targeted therapy that Dr. Sarosiek had presented. And when she mentioned that, I was also fortunate that it had just recently been approved, but I was already aware of it and kind of knew that the side effect profile was better on it. So I was very comfortable when she brought that up with moving to that. So I think just knowing the side effects I was dealing with, that there was a good chance a lot of it was related to what I was on, and that the newer version of that seemed, based on the data, those side effects were improved with the new stuff, if that makes sense. So it's just, at the end of the day, a lot of it's just doing your own research, and then some of it's just, okay, here's what I know, but doctor, I trust you. What do you think?
And to your point, it's the conversation piece.
Right.
Dr. Sarosiek, from your vantage point, again, you see lots of different kinds of patients with different preferences. How many times are you seeing people who are nervous to even talk about side effects, or, and how do you address that? So we've heard from other people, for instance, if I bring this up, I'm worried my doctor's going to take me off of this and it's working well, or how can I figure out how to keep this as my course of treatment, because I want to preserve as many options as possible. So what are some of the things that you are hearing, and how do you address them?
Yeah, I think that, a lot of, I think a lot of patients are comfortable, discussing their side effects. That's my experience, at least, that they're comfortable saying what it is that's going on without having to worry that we're going to adjust their treatments or change their outcomes because we stop therapy or change therapy. And so I would say most patients are comfortable saying if they have a side effect. I think, although maybe I have some patients that are scared to tell me that they have side effects, but I think that on the other hand, I do think I have some patients who don't want to know about potential side effects from treatment. A lot of patients want to know what can I expect so that if it happens, they're aware and they're not worried. But once in a while, I'll tell a patient, well, this side effect might happen. They say, no, don't tell me. I don't want to know, because either they're then going to just worry it's going to happen, or they feel like they might manifest that for themselves if they know about it and hear about it. So again, it's a little bit of trying to feel out what the patients are comfortable with hearing in terms of side effects. But I hope I, make patients comfortable to know that they can tell me about their side effects without me just jumping to immediately making a treatment decision for them just based on them reporting side effects, and that we can then still have a conversation about, well, is this a side effect you can live with, or is one we need to change your treatment because of them?
And actually, Jason, what were the main key side effects that you were experiencing that brought this discussion up for you?
Mouth sores were probably the biggest one. It was brutal. I got a lot of mouth sores. I was starting to experience some joint pain, which, sometimes the side effects, it can be tricky trying to determine, is this from the treatment or am I just getting a little older? I don't know. But I was getting the sense that I was, it was a pretty big or sudden increase in joint pain. The blood pressure was a little higher than I would have liked. And then the platelet count, while not dangerously low, was a little on the low side. And from what I had been reading on the newer version, it seemed like a lot of those side effects had been improved on the new stuff. So yeah, I was pretty comfortable moving. I was responding well. It was just annoying side effects. So, and those are the main ones.
Thank you for sharing that. Dr. Sarosiek, you've touched on this already, but just to kind of go into a little bit deeper, how do you navigate the conversations? Because again, people have different preferences, and there is that mental hurdle of, not wanting to maybe make too much of a deal about side effects in the case that the doctor's going to force me to go off this, treatment, and I don't want to run out of options, or I want to maximize my time here with this one because it's effective. How do you have conversations about that? Leaning into, here's how some ways that we can try handling some of these side effects and see if it works, or lowering dosage. How do you have that conversation with people?
Yeah, usually if patients have side effects, then, typically I try to feel out, is there anything that they would like to do about them? If someone has, mild loose stool, like once every few weeks, they might say, oh, forget it. I don't, it doesn't really bother me. I'm just telling you about it so that you know. And then usually my next approach is to try to find some supportive care measurement that we might be able to do. I have a lot of patients on the treatments we use for Waldenström's that have loose stool or diarrhea, and typically adding fiber to their diet, like a fiber supplement once a day, is actually quite helpful for that. And then it treats it and they can continue on the same dose. So for a lot of the side effects, the first thing I offer is, one, does it bother you? And then two, let's try some supportive measure. And then the next thing, if that supportive measure doesn't help, then I think it is a conversation about whether or not we want to decrease or change the dose. And in that case, I try to, bring up any data that we have in that setting to, reassure patients if I can, if there's data with that particular treatment, that if we go down on the dose, that the patients will, still have very good outcomes. And often we have that kind of data to help us guide if we should reduce the dose or not. So we think about that, but usually we try other kind of supportive things first, so that we can try to stick to the regimen that's kind of proven in the literature.
Wonderful. Thank you. I know we're at time, so wrapping this up, what are the next, there's this long-term relationship that's happening. What are the major other points here, where major discussion tends to happen? I mean, imagine it's talking about the active surveillance, or sometimes patients call it watch and wait or whatever, but talking about that, as well as at any point that treatment may need to come up. What are some other, is that the case? And how do you both approach this as an ongoing relationship, that's different than other cancers, of course? And maybe, Jason, we'll start with you.
Yeah, I mean, it is kind of this new concept of watch and wait in the sense that I'm on a treatment, but I am sort of at the same time in watch and wait, because while I could potentially get many more years out of this treatment, the reality is at some point I'll start to slowly lose the response. So I guess from a mental standpoint, I'm pretty good at being able to compartmentalize. I'm fortunate enough that I can move through my day without it weighing on me. I, of course, think about it. You get reminded twice a day when I go to take my pill, of course. So, and I just try to stay up to date on what's latest and greatest. And but ultimately, the day will come when Dr. Sarosiek and I will have to huddle up and figure out what the next best step is. And the good news is a lot of options, a lot of really good options. So I think that lessens my anxiety, knowing that there'll be a lot of good options on the table for me when the time comes. And we always typically we meet every 3 to 4 months. So I'll go in for blood work, which is really helpful for me because we can kind of get a pretty good idea, not just on the disease itself, but how's my overall health, because you want to avoid any pitfalls there as well. But then it's not uncommon, as Dr. Sarosiek knows, I typically will ask, like, hey, what are you seeing? What's the latest and greatest? Any thoughts about the future? So that's been my approach on it.
And from my perspective, I would say, part of what drew me to oncology, and which I love about Waldenström, so we have this luxury to be able to do this in most cases, is, just get to know the patient and be able to sit down and talk about running or running shoes or like family and vacations. And that's really what I love about what I do, but also, partly I love it, partly it's great because I know the patient, I get to know the patients, but partly that's how I know how the patients are doing. If I know a patient is a runner, or I know a patient, loves to spend their time golfing or loves to spend their time with their grandkids, and then they come in and they say, oh yeah, I've cut back on my running, or I'm not hanging out with my grandkids. And that's what I love, is I don't necessarily have to say what are exactly your symptoms. I just know them well enough to be able to realize that if they're not doing what they love to do or what they're usually doing, that something has changed. And so part of active surveillance or watch and wait, or even, monitoring someone on treatment is, I love getting to know them and then being able to tell if they're not able to do the same things that they were doing, or, they just show up one day and seem a little bit different than they have been at every other visit that we've known for months or years. Then, something's off with their disease and we should look into it. But that's what I love about oncology, and what I do now is just really getting to spend time with my patients, really getting to know who they are.
And if I could just add really quickly, just for any doctors that might be watching this, like I'm confident on one hand that Dr. Sarosiek, there aren't many doctors in the world that know this disease and the science around this disease as well as her, but she also knows me really well, and that's critical in the doctor-patient relationship.
I love that. I love that you're both highlighting this other part, because again, kind of describing it as like a long-term relationship, that's very different than maybe, I had, my hematologist oncologist, and at the 5-year mark, it was like a very clear, see you later, and we talk a lot about survivorship in other spaces, but this is this ongoing conversation. And the fact that that Dr. Sarosiek knows her stuff, she's at the top of the game, but really the difference for you has been this, like you talked about, this anxiety and this mental load that you had to work through daily. You came up with your own things, but the fact that Dr. Sarosiek, you go and you approach people, you want to learn more about who they are beyond the diagnosis so that you can treat them as a whole person and not just about the disease specifically, because that allows you to understand how different options might impact them and their quality of life. I think that is just such an amazing thing that's happening. And I really do hope that both the patients and care partners and the physicians who see this will take that away. Any last thing you want to both mention that you think is really important in the context of having patients and physicians, in this Waldenström space be partners? What, are there misconceptions? Are there any other things that people are missing that you think would really benefit them, whether it's for both patients and physicians or either? We'll start with you, Dr. Sarosiek.
Yeah, I think it's important to, in my perspective, I think find a physician that, is open to learning and is willing to work with you within your space. I mean, we're all different people. As we all know, we were born into families that maybe have different personalities, and we learn to work together. And sometimes, we find friends along the way during life that are more like family because they're people you really relate to. And I think you want to find a physician like that can meet you in your space. whether it's a different, sometimes, you have different personality issues and maybe you want to find a different doctor, or maybe you want to find someone who can work better in the way that would make you most comfortable with your disease. So I think it's worth getting second opinions, or, meeting other physicians, and really find someone that you feel like can be your partner through the journey. I think that's really important. I try my best. I know I fail in some ways, but I really try my best to be a partner with my patients, and hopefully, patients are able to find someone who is able to do that with them.
Take care of your health, both physically, mentally. Join support groups. If you have Waldenström's, go to the iwmf.com and ask questions ask your doctor lots of questions. Don't be afraid to seek multiple opinions, and ultimately find a doctor that you're comfortable with, that knows this disease inside and out, if possible, or at least ask your doctor to be in touch with a doctor that knows this disease inside and out. That I guess, if I had to summarize as best I can, that's what I would do if I was diagnosed with Waldenström's.
Wonderful. I actually would be remiss not to ask one last thing, which is, Dr. Sarosiek, do you ever talk about clinical trials with your patients? Because it's a huge topic, and I'd love to hear Jason's perspective as well, but sorry to extend this, but this is actually very important. In a space where there's so much development, Dr. Sarosiek, what is your mindset in terms of the research, and how to bring that to patients? When do you bring it up to patients?
I am a huge advocate for clinical trials, and in general, I think especially in academic institutions, we tend to use clinical trials a lot to be able to offer novel therapies to patients. That's how we move the field along. So I really do advocate for clinical trials. Often, as Jason mentioned, he'll come in and ask about novel therapies. So often it just comes up in conversation with patients as they ask what's new, and we'll talk about clinical trials. But always, if there is a trial available that a patient would qualify for, I always bring it up as a potential option. Some patients can't participate because of logistics and not being close to a center with clinical trial, but I will always bring it up because I think it's the best way that we can move the field forward. So if a patient is eligible for a trial, it will certainly come up in conversation with me for sure.
Yeah, I mean, I'm still responding well, so I'm not there yet. But I do, as Dr. Sarosiek mentioned, I do make it known that I'm very much open to a clinical trial when and if the time comes. The good news is that there's so many new options now, and they're making advances every day. The challenge is there are so many options that the doctors are trying to figure out what's the right sequence or order of treatments, which one is more effective and safer than the other. And the only way we can get the answers to those questions is by patients taking part in clinical trials. These aren't, I think a lot of people think clinical trials that they're just the guinea pig for, but no, there are a lot of great options, and the doctors are looking to get answers. So I've made it known that I'm very open to a clinical trial when the time comes. So
what from the patient perspective would be your major considerations on whether you would want to go on a particular clinical trial?
Yeah, when the time comes that I start losing the response to this, I think for me, I'd be very interested in a clinical trial that combines agents that aren't chemotherapy that will eventually be able to give me a break from treatment, time off treatment. And there's a lot of progress being made on that front. I know that's a priority for a lot of the centers and doctors out there. So I think that would be probably the big consideration, is combining agents that aren't chemotherapy that might be able to give me some time off from treatment.
I mean, that makes perfect sense for sure. But if we were to dive in, can you share a little bit more about what it is that's coming up for you? Chemotherapy, it sounds like maybe the side effects and the quality of life issue. And then time off treatment, of course, that's obvious. Who doesn't want a break? But can you describe why that's so important for you and what's driven you to that point?
In terms of getting a break from the therapy? Yeah, I mean, I think that the targeted therapy that I'm on now, there doesn't seem to be a lot of risk long term, but at the end of the day, it's still relatively new, and we don't really know that. I also know that these treatments aren't cheap, and it's pretty taxing on the healthcare system to remain on these things. So I know that's a consideration. But the end of the day, it's a drug. it's not there are no free rides when it comes to these medicines, and each one of us is different, and I just don't know how it's going to impact me long term if I stay on this for 10, 15, 20 years. I mean, I likely won't be on it for 20 years, don't get me wrong. But, as we say in the Waldenstrom's community, if you know one Waldenstrom's patient, you know one Waldenstrom's patient. I think that can be applied to a lot of different cancers. But the bottom line is I just don't know what the long-term ramifications of continuous therapy. So it would be nice to just to not be on a drug for a period of time.
Wonderful. And Dr. Sarosiek, any last thing you want to say about that? We know, like Jason mentioned, the term guinea pig. I know that's a very common misconception. People get a little nervous and they think of placebo, and it's, hey, there's no placebo. You're getting care no matter what. But is there anything else that you think would be helpful for patients to understand, both in terms of guidance for them, but also in terms of, when a doctor is talking about it, like questions that they can maybe ask that might be helpful?
Yeah, I think those are, a couple of concerns that patients bring up when they hear clinical trials. So one is, are you just testing something that you don't know anything about on me? Or two, am I going to get a placebo so I won't be getting any treatment for my cancer? Or the other thing that patients bring up is, does this mean that this is the last option for me, that, that I'm going to be dying with this cancer soon? And I think that it's important for patients to know that's not the case, that often we have many trials for patients that have never been treated before. And this is just going to be their first treatment in decades of life that they'll live with Waldenstrom's. And so I think it's not, it's important for patients to know that it's not, that they're not going to get their cancer treated, or that we're trying something totally new on them, or that it means it's the end of the road. It's often a way to get novel therapy. So currently we have a clinical trial that uses 2 oral therapies that we know independently work very well in Waldenstrom's, and we use them independently as standard of care. But the trial is trying those 2 together so that you can use them for a limited amount of time and get a better response. So often it's a way to get novel therapies or advanced therapies that otherwise wouldn't be available as standard of care.
Right. Sometimes you hear people say tomorrow's treatment today. And while clinical trials may not be right for everybody, I think it's great to have the conversation so people can choose right for themselves what is right for them. Well, thank you both so much, Dr. Sarosiek and Jason, for joining this conversation. I think you really highlighted a lot of the nuances that come up in the conversations between the physicians and the patients, and you're a great example of how partnership can work really well here. So thank you both so much.
Thank you, Jason, Dr. Sarosiek, and Stephanie, for such a great discussion today. It is so important to be empowered and to lean into the communication so that you and your caregivers can make informed decisions about your care. A reminder, we want to hear from you. A survey will pop up when this program closes. Thank you again to our sponsor, Pharmacyclics, an AbbVie company, for its support of our independent patient program. And to our partners, LLS. Check out the links on the side to the LLS websites. Check out their Information Resource Center, which provides free one-on-one support, and the IWMF, who has over 60 peer support groups worldwide, where they share experiences, discuss concerns, and exchange information. Until next time, I'm Tiffany Drummond signing off, and on behalf of The Patient Story, thank you for watching.